Good evening. Dr. Kathleen Hoeger. I'm grateful to the organizing committee for their invitation to speak at the annual PCOS Society of India. My talk today is on polycystic ovary syndrome, mood and anxiety disorders across the reproductive lifespan. I have no financial disclosures to report. By way of outline for this presentation, we're going to review the prevalence of mood disorders and anxiety in PCOS. We'll discuss what is known about the prevalence across different time points and the impact of treatments. And finally, review the PCOS International Guidelines on screening, diagnostic assessment, and treatment of emotional well-being. So first of all, what is emotional well-being? It's a broad topic, and what we know about the connections between PCOS and emotional well-being is that there is a clear association between diminished well-being. And there is a focus now on improving the screening and detection of these disorders, which affect emotional well-being and are commonly associated with PCOS. So how do we assess mood disorders in PCOS? And right now, there's a significant variation in the diagnosis and management of mood disorders in our clinical practices. There's a general underappreciation of the extent of the disease. The role of our assessment tools is not well characterized, and we still don't understand the best treatment options for the condition. So it falls under the broad category of the psychological features of the quality of life. And we know that anxiety and depression are part of that quality of life, but it also includes things like poor body image, psychosocial dysfunction, and eating disorders. For today's presentation, however, we'll be focusing on anxiety and depression as a key mediator of quality of life. So mood disorders are based on the DSM-5 Depressive Disorders Index, and these include major depressive disorder, dysthymic disorder, dysphoric mood dysregulation disorder, premenstrual dysphoric disorder, and depression not otherwise specified. And if we categorize all of these disorders, the prevalence worldwide, not specific to PCOS, is approximately 3 to 18%. So that's the background rate of mood disorders in the population. So what about mood disorders in PCOS? Many studies now are associating depressive symptoms and depression more commonly in PCOS, and it also is associated with daily fatigue, sleep disturbance as prominent features. In a meta-analysis by Dr. Dokras' group, they looked at the prevalence of depressive symptoms, and 44% of women with PCOS versus 17% of control women demonstrated depressive symptoms. And this was persistent in BMI-matched studies. And here you see these represented as a prevalence of 44% in PCOS in the green versus the control women in the orange. And what's also notable is that the severity, those with moderate or severe disease, was higher in women with PCOS than in those without. And here are the actual studies that they looked at for this meta-analysis. And you can see the majority of them do show a significant association of PCOS and depression with an odds ratio of 3.78. And here are the symptoms of severity, and again, significantly an odds ratio of 4.18. So these studies are both from clinic-based assessments and community settings. And notable in both of these settings, we did see significantly more severe expression of depression. And these data were adjusted for BMI. But there are limitations to the meta-analysis. Many of these studies were of smaller sample sizes, and not all used a formal diagnosis or a clinical assessment in the diagnosis. So what about the features of PCOS? Are they in any way indicative of depression? As we know, the features are oligomenorrhea, hyperandrogenism, and ovarian morphology. But there are significant findings in some studies and not in others. So at this point in time, the fertility in infertile women in one study did not show a difference in the incidence of depression, whereas in a Chinese study, there was a significant increase in depression in infertile women. Across the board, there's a weak association between a hirsutism score and depression scores. And there are some very small studies that indicate a link between the metabolic disturbance and depression. But even taking all of this into account, these are very small effect sizes. So not enough to explain individually why women with PCOS have higher rates of depression. But there are studies in the general population that demonstrate obesity leads to depression. So these are data, again, from general studies, not PCOS, but women who have obesity have a 50% higher odds ratio of developing depression than those women who are of normal weight. So what about anxiety? Population-based studies also report anxiety presence in PCOS at higher frequency. A Swedish study showed an increased odds ratio for anxiety of 1.37, and a Western Australian hospital database showed an incidence of 14% in PCOS versus 5.9% in those without this diagnosis. Looking again at the meta-analysis that we did for depression, we see in anxiety a similar percentage of women with PCOS reporting anxiety versus a much smaller group in the controls. And here again are the meta-analyses adjusted for BMI. There was an odds ratio of overall anxiety of 5.62, so very significant. And when they are adjusted for BMI, the moderate and severe symptoms was even more notable with an odds ratio of 6.55. If we take out only the studies that were BMI matched and look at the presence of anxiety, again, we see an even stronger correlation when matching for BMI between PCOS and anxiety. So we asked the same question, are features of PCOS correlated with anxiety? Hirsutism and androgen levels do not appear to be associated with anxiety and PCOS, or again, similar to the depression studies, have very small effect sizes. However, there are very interesting data now coming out pertaining to maternal androgen exposure in animal models with increased anxiety scores in offspring. So there may be an epigenetic contribution of androgens, and we now have some evidence in PCOS mothers that do have higher rates of offspring with anxiety and depression. So this is an evolving area of interest, and androgen exposure and anxiety scores in offspring may be something quite developed. What is the impact of age on the prevalence of mood disorders in PCOS? There are very few studies with a longitudinal assessment of depression and anxiety in PCOS because most of the data we've presented thus far include women in the mid-reproductive years, so ages 20s to 30s. However, we do know that the prevalence of depression and anxiety in adolescent women has also increased, but it's based on limited data. There was a meta-analysis several years ago that looked at this question, and they did score higher in depressive and anxiety symptoms compared to controls. And in a recent study, a small study of 60 adolescents with PCOS compared to those with type 2 diabetes and no PCOS, demonstrated an increase in depression symptoms in those with PCOS. 60% of those with PCOS had depression compared to 39% with type 2 diabetes. So not an exact control match, but controlling for obesity. So again, what is the impact of age on prevalence? We have very limited longitudinal data. There are data coming out of the North Finland birth cohort, which, as you may know, is a long follow-up of women born in Northern Finland and now have been followed between up to age 46. They used a self-diagnosis of PCOS, and they looked at women when they were 31 years old and again at age 46. They looked at women who had neither oligomenorrhea or hyperandrogenism, or those with individual features of each, or both. And those with both, they determined had PCOS. So here are the data at ages 31 and 46 for the prevalence of depression. So starting with the control women, we do see an increase in prevalence in control women between ages 31 and 46 of the prevalence of depression. When we look at women with oligomenorrhea alone, they had no significant difference from the control women, although they also showed an increase. However, those with hyperandrogenism alone or with PCOS, including both of those features, had a significant increase at baseline age 31, but also a significant increase at age 46, with PCOS showing the most significant impact. On the bottom panel, you see the crude rates here with the odds ratio, 95% confidence intervals, BMI adjusted and testosterone adjusted. So in each of these cases, we see an impact of PCOS on this diagnosis, controlled for BMI and androgens. What about the overall health-related quality of life? As is true with depression and anxiety, most studies indicate a lower health-related quality of life scores in women with PCOS. This is impacted, as we noted earlier, by anxiety, poor body image, low self-esteem, and depression. But infertility and body weight domains have the most impact on quality of life. But that may be because these studies have been done primarily in clinics, which are going to be where people present for concerns about body weight or infertility. So again, we're looking at the North Finland birth cohort, and this is quality of life at 31 and 46 years. And to take you through this, the control women are here in the dark blue. And as you move towards the center of the spider web, you get worse symptoms. And when you look at the PCOS, almost across the board in all of these features, we are seeing significant changes in vitality, in discomfort, in sleeping. And this is at age 31. At age 46, across the board, even in the control women, we are seeing a lower quality of life as women age, but this is again significantly more in the red with PCOS in many of these features. Do we have any predictors of longitudinal depression risk? So we don't have a lot of longitudinal data, as I said. This is data that comes from a clinic at University of California, San Francisco, and they had depression screens at age 29, and they repeated them at age 36. So at baseline, they had 36% screened for depression. And follow-up at age 36, they had 32% screened for positive depression. So they didn't have a significant increase in the population as a whole. But what they were able to demonstrate that each 1 kilogram per meter squared unit increase in BMI was associated with a 9% increase in enduring depression. Other parameters that contributed to depression were some of the metabolic features of PCOS, but these again were partially explained by this increase in BMI. The androgen measures, including the hirsutism scores, did not associate with higher risk of enduring depression. So again, this is tracking more with obesity and BMI. What about other reproductive states, postpartum state and PCOS? There are very few data on the prevalence of neuropsychiatric disease in PCOS in the postpartum state to women without PCOS. However, recently there was a large US insurance claims base with a retrospective cohort design, women who did not have pre-pregnancy depression, but the odds of postpartum depression and perinatal depression were higher in women with PCOS. So in perinatal depression, there was an odds ratio of 1.32, and in postpartum depression, it was 1.5. And other features such as race, we don't have a lot of data on that as well. This is again from a US database and looking at white women and Black women in the US. We did see evidence of higher rates of anxiety in white women and higher scores in anxiety, but there was really no difference in the rate of the presence of depression or depression scores by race. So finally, what about mood disorders in the peri and postmenopausal women with PCOS? The menopause transition and early postmenopausal years are associated with an increased risk of mood disorders in the general population across many studies. However, once a woman passes through menopause, there is likely a decreasing incidence of mood disorders, at least in the general population. Cross-sectional analysis from the SWAN study, which was a longitudinal study of perimenopausal women in the US, did not reveal any differences in the prevalence of depression between women with presumed PCOS and control women at baseline. And these women were recruited in their late 40s and followed over time. But we are in need of further study of women with PCOS as they approach and transition through menopause for better understanding of this. So what about the impact of treatments on mood and anxiety disorders? There are not a lot of data here either to examine the traditional first-line treatments. And as you're well aware, these treatments include birth control pills, metformin, and lifestyle intervention. But we do have some evidence of lifestyle modification on mood and quality of life. And again, using that PCOS Q scale, which includes domains for emotions, body hair, weight, infertility, and menstrual problems, common issues in PCOS. This was a trial that didn't have a control group, but used lifestyle modification and randomized to diet and exercise, or exercise alone for 20 weeks. They had 94 start, but only 49 women completed the trial. They were mid-reproductive age with a BMI of 36. And each of the groups had significant reduction in body weight. And all groups had significant improvements in the domains of the PCOSQ without any difference between the different arms. In our own group, we've looked at adolescents with PCOS assigned to lifestyle, and we randomly assigned them metformin or placebo. When we looked at the difference between metformin and placebo, there was no difference between baseline and 24 weeks with respect to PCOSQ, but all of the domain features had a significant increase in both groups. And finally, the AL-PCOS trial from Dr. Dokris's group looked at infertile women who were also overweight and assigned them for 4 months to a lifestyle program, birth control pills alone, or a combination of birth control pills and lifestyle. And then the primary outcome was looking at live birth rates. But for the purposes of looking at depression, they looked at the end of the 16-week intervention phase. And they did see significant improvements in depressive symptoms with birth control pills, with a slight reduction in lifestyle as well. And with anxiety symptoms, a significant improvement with lifestyle modification with a reduction in birth control pills as well. And when we look at the PCOSQ, these are each of the 3 arms. The lifestyle group did have some improvements in weight and infertility domains. The birth control pill had similar plus body hair improvements. But when we combine those, all 5 features of the PCOSQ improved in a combination of birth control pills and lifestyle modification. So finally, our international guidelines. The international consensus, as you know, now 3 years ago, published their official guidelines. It was workup, diagnosis, and management of PCOS based on a systematic evidence-based review, and it took several years to complete. There were 6 working groups, one of which was devoted to emotional well-being in PCOS. The guidelines have been endorsed by all the major international organizations that take care of PCOS, including AEPCOS. The tools identified for screening and clinical interview were felt to be easy to perform and readily available. And these examples include the PHQ-9, the GAD-7, and the PCOSQ, which we've reviewed. Their recommendations are listed here. Health professionals and women should be aware of the adverse impact of PCOS on the quality of life. Health professionals should capture and consider women's perceptions of their symptoms, impact on their quality of life, and personal priorities for care to improve outcomes. And the PCOSQ may be used clinically. With respect to depressive and anxiety symptoms, health professionals should be aware that in PCOS there is a high prevalence of moderate to severe anxiety and depression, and there is an increased prevalence in adolescents. Symptoms should be routinely screened in all adolescents and women with PCOS at diagnosis, and if this screen is positive, there should be further assessment or referral. If treatment is warranted, either psychological therapy or pharmacological treatment should be offered to women informed by regional practice guidelines. The optimal interval for screening or rescreening is not really known. A pragmatic approach would be to include repeat screening using the risk factors, comorbidity, and life events, such as, as we talked about with postpartum and peripartum. And finally, just an example, assessment of anxiety and depressive symptoms involves risk factor assessment, symptoms, and severity. They should be screened in a 2-step approach. Initial questions could be, over the last 2 weeks, how often have you been bothered by feeling down, depressed, or hopeless, little interest or pleasure in doing things, feeling nervous, anxious, or on edge, not being able to control or stop worrying? If the woman screams positive to any of these questions, then assessment of the factors, including culturally appropriate and regional tools, should be performed or referred to an appropriate professional. So in conclusion, psychological concerns such as depression and anxiety are found in higher prevalence in women with PCOS across the reproductive lifespan, from adolescence up through to the perimenopause. The impact of aging, reproductive stage, or specific PCOS symptoms on the prevalence of psychological concerns is uncertain, but there is evidence that enduring symptoms are increased with increased BMI. Lifestyle interventions may serve to improve some aspects of psychological dysfunction. International guidelines recommend the screening for all of these disorders with appropriate referrals as needed. Thank you very much for your attention, and I'm happy to answer any questions.